Hello everyone, welcome to new DigiTrash webinar entitled AI Application in Medical Treatment. Today's presenter will be Ivan Knežević, professor at the Faculty of Information Technologies at University Mediterranean in Podgorica. Right now he's in Germany where he's working on his PhD research, and he will tell you about this later on. And I would like to give floor to Ivan to tell us more about this very interesting topic.
Okay, thank you. Thank you, Tamara. First of all, allow me to say a few words about the SEAST project, or as it is shown here with mouthful acronym, the Southeast European International Institute for Sustainable Technologies. This project emerged as a result of international cooperation among 10 countries of the Western Balkans, aiming to build an institute for hadron or heavy ion cancer therapy with specifications for carbon ion therapy. This therapy promises more precise and effective cancer treatments with significantly fewer side effects compared to the conventional treatment methods and much higher success rate. SEAST is designed not only to fulfill its medical role, but also to have a scientific and research-oriented character, as it is envisioned at least 50% of its working capacity will be dedicated to the scientific community. So, for example, ESA, European Space Agency, expressed their interest into using the capacities of this project for testing their equipment for heavy ion radiation, which is supposed to simulate the radiation from the outer atmosphere to which cosmic radiation to which astronauts are exposed. As I have already mentioned, hadron therapy is an innovative method of radiotherapy, and it uses hadrons or heavy ions for radiological cancer treatments. This type of therapy represents an advancement over conventional radiotherapy methods due to its ability to precisely target the tumor cells while minimizing the damage to the surrounding healthy tissue. During the therapy, hadrons are first accelerated using a linear accelerator, followed by a circular accelerator, which you see now in the picture. This is now the control room from which everything is controlled, actually. As I said, everything is accelerated first in linear accelerator, followed with circular accelerators such as cyclotrons or synchrotrons to increase the energy of the beam. The direction these hadron beams are then guided through this high precision through a series of magnets to the treatment room where a patient is when they are aimed at the tumor. The unique feature of hadron therapy is so-called Bragg peak phenomenon, where hadrons deposit the majority of their energy at the end of their path. This allows physicians and medical physicists to precisely target the tumor while minimizing the damage to the surrounding healthy tissue. The energy deposited in the tumor cells damages their DNA, thereby preventing further division and growth. And hadron therapy shows great promises in treating various types of cancers, particularly those radio-resistant to other treatments, to standard therapies, or to the cancer that are located near the critical body structures, near heart, near lungs. And its effectiveness and safety are best demonstrated by the fact that it's currently the only cancer therapy recommended for pregnant women, as it poses no risk to the fetus. So women don't have anymore to choose between the therapy or delivering the baby. A typical radiotherapy process begins with the data collection, which involves imaging the cancer using various methods, such as CT scans, MRI scans, PET scans, etc. And after analyzing these images, segmentation is performed to determine the exact location of the tumor and the surrounding healthy tissue. With this data, the next step is treatment planning, which involves dividing the treatments into smaller segments to ensure that even dose distribution within the tumor is delivered with every therapy. But before we can start the actual treatment, the therapy plan is carefully checked to ensure that the tumor is correctly targeted and that exposure to the surrounding healthy tissue is minimized. This allows us actually quality assurance, which is also maintained through continuous monitoring and verification of the delivered dose during the therapy, as well as tracking the patient's and tumor's position to ensure the consistency and the precision throughout the treatment. The treatment itself is organized in multiple sessions, depending on the type and the stage of the tumor. Of course, this is all of this is previously determined in the treatment plan. And furthermore, the continuous monitoring of the patient and tumor behavior after the therapy is essential to assess effectiveness of the treatment and make any necessary adjustments. And this procedure is repeated several times until, usually to several weeks period, until the treatment is completed. Now we have a question: where can AI help us in this radiotherapy workflow? AI can significantly enhance radiotherapy workflow in several ways. First, it improves diagnostic imaging by enhancing image quality and detecting abnormalities much earlier and more accurately than we are able to do it only with separate imaging as we do now. This can help doctors to make better treatment decisions and to create the entire plan much more accurately. Another key application is automatic segmentation of these cancerogenic zones. So instead of manually outlining the tumor, which radiologists usually do when they have it, it's a very tedious process. AI quickly and consistently identifies this cancerous tissue, saving the time and reducing the human error at the same time. And finally, AI aids in dose calculation and beam delivery planning, as it optimizes the radiation dose, beam position, delivery method, and at the same time ensuring the precise targeting while minimizing harm to the healthy tissue. So overall, AI makes radiotherapy much more accurate, efficient, and much more personalized, because most of these calculations are very patient-oriented, meaning that they are different for every patient depending on the stature of the tumor, the position of the tumor, position of the patient, etc. This multimodal imaging is a key part of the radiotherapy planning. To create an accurate treatment plan, we need multiple imaging modalities, like, as I mentioned before, CT scans, MRI, and PET scans. And combining these images helps us get a complete picture of the tumor and surrounding tissue. But however, co-registration or like overlapping these images, so between different images, is essential to align them correctly. This is a problem. So this can be very challenging because patients move between imaging sessions, or sometimes between different imaging sessions can pass a week or two, and as well the cancer grows. Their anatomy may change. All of this can cause some inconsistencies. To minimize the number of imaging sessions, we follow so-called ALARA principle, or as low as reasonably achievable. This helps us to reduce radiation exposure while maintaining the accuracy, because also the radiation exposure that we provide during the imaging can affect the final calculation and tumor itself. Major challenge here is the formable image registration. This technique finds the so-called transformation vector fields that map images from one modality to another, at the same time accounting for anatomical changes and ensuring precision. So basically what we do, we find some anchor points in each of these images, and we calculate the transformation between the images themselves, so we can, when we do the overlap, this calculation is done perfectly. So basically by addressing these challenges, we make this multimodal imaging more reliable and more efficient. As I mentioned before, tissue segmentation is one of the places where AI actually can help the most, and where we spend most of the time basically when we do this calculation. Because tissue segmentation is critical and yet very time-consuming task in radiotherapy, and radiologists are often overwhelmed with work, and this manual segmentation is tedious and very prone to variations. Even the same radiologists, as we tested it as well, can produce sometimes different results when segmenting the same tissue in different times. So see, it's very also depending on the person who does it and on the final result. So doing this segmentation automatically was a very challenging task. These variations between different segmentations matter because segmentation have a huge impact on the treatment outcome, because the radiologist actually needs to outline the tumor cancerogenous tissue for us. We're not allowing AI to do it themselves. Still, radiologist needs to confirm the final decision. And inaccurate segmentation can lead to incorrect targeting, affecting the effectiveness and safety of the therapy overall. That's why tissue segmentation is considered one of the most important tasks for AI in medical informatics. And automating this process aligns perfectly with what AI does the best: processing large amounts of data quickly and consistently, reducing variability and ensuring precision in treatment planning. During modality selections, we differentiate two basic modalities. First is, as you can see here in the picture, is IMRP, or intensity modulated radiotherapy, and the second one is CI, or carbon ion therapy. Selecting the optimal treatment, so between these two treatments, selecting the optimal treatment for each patient requires very accurate predicting of the outcome. So in radiotherapy, this involves estimating two key probabilities. First one is TCP, or tumor control probability, which represents the likelihood of successfully eradicating the tumor. And next one is NTCP, or normal tissue complication probability, which represents the risk of causing damage to the healthy tissue. And we use deep learning, and deep learning plays a crucial role actually in this process by enabling us to predict the most effective radiotherapy treatment modality for each patient separately, based, of course, on their individualized data and complex patterns that traditional methods might actually miss. During treatment planning, when planning radiotherapy, we carefully adjust radiation parameters to maximize precision and minimize harm to the healthy tissue, as I mentioned before. So first, we determine the patient's position, since every small change can affect the accuracy. Next, we optimize the beam incident angle, so the angle under which the beam comes to the patient and to the healthy body, in order to target the tumor while protecting the healthy tissue. And we also calculate the dose intensity and delivery methods to match the tumor type, location, tissue that is the tumor consists of, etc. So finally, we optimize the treatment plan to ensure the best outcome. And artificial intelligence is essential at every step of this process, helping us analyze the data and make these precise adjustments for safer and more effective treatments. When I talk about those calculations, in hadron therapy, the radiation dose is carefully calculated in order to destroy the tumor tissue while minimizing the damage to the healthy tissue. And we of course, we don't want to test on the patients. And what we do, we use simulations. We actually use Monte Carlo simulations for precise dose modeling. And these simulations accurately track how particles move to the patient's tissue by repeating this experiment with random sampling. They predict how radiation will spread and how is calculated the dose at each point. Monte Carlo simulation works by generating random numbers as input parameters and simulating how the system behaves over time and space. This approach ensures high accuracy, but the problem is that it can be very resource and time consuming. And fortunately, we have tools from high energy physics that we actually use in the institute where I am to make this process more efficient. And on the slide here, as you can see, shows comparison between a clinical dose plan, so the plan that's done by a clinical physician, and the Monte Carlo simulation. And you can clearly see how much more precise the simulation is. If you take into account here, like, for example, here we had this higher dose on this part of the tissue, but here Monte Carlo simulations find that there is part of the healthy tissue that we didn't take into considerations. And after several simulations, we were able to drop the dose dosage on this part of the tissue and increase it again in order to spare this part of the healthy tissue. But as I said, the problem is that in order to do Monte Carlo simulations, we require some very sophisticated equipment like GPU nodes that can cost hundreds of millions of dollars in order to do the simulations in, let's say, in required time period, because we don't usually these simulations can last for weeks. We can't allow patients to wait that much, so we use some experience we had from huge data analysis from the high energy physics that kind of have the same problem as we do, meaning that they can't wait for too long to have the results. And some of the algorithms that they developed, we successfully implemented here. And as you can see, we already have some results that are published in journals and also can be applied in therapy directly. Another problem we usually have is adapting the beam to the tumors that are positioned on organs that move. Usually, this means like lungs, stomach, or diaphragm, or liver. Basically, any or internal organ that is subjected to any kind of movement. So, as you can see here on the image, this red represents the treated area, so the area that we are irradiating heavily during the treatment. But as the patient breathes, the cancerogenous tissue moves. So in every segment, we are irradiating around 30% more on the healthy tissue. In order to avoid this, what we want to do is predict the movement of the cancerogenous tissue in order to move the entire gantry, the entire this device that leads the beam to the patient with the predicted patient moves. So we never deliver more energy than required to the surrounding tissues. How it's done? Basically, breathing is something that is subjected to the external stimuli. So what we usually do, we sedate the patient in order to exclude any external variable like emotional response to the patient, in order to bring the breathing and heart rhythm in a sinusoidal pattern. This allows us to predict the movement of the body much more precisely. But what we also need to do, we are using PET scanners in directly imaging the patient whilst he's still on the table. And at the same time, we use the beam that because we use PET scan because PET scan allows us to actually see the beam or see the results of the beam, and we are able in a real time to track the patient movement of the cancerogenous tissue and to adapt to it the movement of the entire gantry in order to precisely lock and target the cancerogenous tissue that we want to treat. However, nothing comes without challenges, and one of the biggest challenges in using AI for radiotherapy is data availability. Clinics often cannot or do not want to share their data, mainly due to some privacy concerns or technical limitations. Fortunately, there are some online databases like cancerimaging-archive.net that provides open access to medical images, but the problem is that they are often limited in scope and quality. One of the other methods that we are currently implementing, and we are hoping it shows great success, is so-called federated learning method that allows us to not share the data directly, but to train, when I say train, I mean train the data within the institution that holds the data. So we can encrypt those data and share only the trainable models, like ones and zeros that does not represent any privacy-based cancer patient data. So we can actually exchange them between the hospitals themselves without posing risks to exposing any private documentation of the patients. Another challenge is computing power. Performing these complex simulations and real-time processing requires significant resources, as I mentioned before, which are often lacking in clinical environments. This problem is very widely known, and what is done now on European level is that we are mapping all the infrastructures that hold these processing power or high computing power resources, and when they are not in use in their institutions, they can give them for training purposes to the institutes like this that can train the data separately on them. Another challenge is the explainability, because we need to understand how AI model works or how they make their decisions, especially when predicting radiation dose, because we don't want AI to let AI make all the decisions. We want them to make a suggestion, but still the radiologist is the one that takes has the last word in this. And in order to do so, we need to understand how did AI arrive to this conclusion. And the key aspect here is this uncertainty propagation, knowing how uncertainties in input data can affect the final dose calculation. And as you saw before, we have many variables that can influence this pattern. And finally, we need to address the outlier detection. Identifying unusual cases or errors in our data is vital to ensure the safety and accuracy of treatment plans. And addressing these challenges is essential for successful AI integration in all. This outlier detection is also something called data poisoning, because some of the, when we call outliers, we mean these margin cases where we have some either extraordinarily huge tumors, or when we need some very high dose of radiation that usually is not done. We are trying not to give huge importance to this case in order not to influence the other cases that we are treating, and we want AI to take into account only there's, let's say, medium cases. With this, I would conclude this presentation, and I'll be more than happy to answer any questions if you have them.
Thank you very much, Ivan. It was really interesting presentation, and I didn't know a lot about this topic, so thank you for clarifying it. And also, I would like to ask anyone to just pose questions to Ivan if they have any. Well, I have a question for you. So I would say that this is a very good application of AI, very beneficial. But does it come with some ethical concerns?
So I was trying to address them during the presentation. First of all is, of course, we never let AI make the decisions for us, because that's why explainability of the data is very important. That's why I said that we need to know how AI arrived to the conclusion it did. That's why when we get the results, when we create a treatment plan, we always do this backtracking and check all the necessary boxes to see what actually happened. Why did AI arrive to this conclusion? For example, in that Monte Carlo simulation that I showed you before, Monte Carlo doing many simulations actually helped AI determine that there is a part of the healthy tissues is behind the imaged area. And when we did the MRI scan again, we actually find out that there is actually part of the healthy tissue. So this part of knowing how AI arrives is, I would say, the major concern. The second one is, the one also I try to address, is the data privacy. Every time when you do with any personal level data, we encounter huge roadblocks in administration in order to get the data. Even when I was working in CERN on something similar, we were analyzing cancer patients' data, and I asked, for example, from Montenegro to get some data from the patients. We had to go through like several ethical boards in order to explain why we need this data, that we're going to anonymize this data, that no personal record is gonna leak from our research, just in order to get maybe like 30,000 cases, no more. So we are trying to address this issue in several ways. For example, one of them is, I mentioned before, is this federated learning. and that's something that in CERN is, there is a spin-off of the project that started in CERN. It's called Caffeine, that actually tried to exchange this model, so not exchanging the patient data, between 3 hospitals in Milan, in Munich, and the third one was in Athens. They were actually collecting only specific cancer, like brain cancer data. The main problem was during COVID, 2 of the radiologists in a hospital in Athens died. And they had only 1 radiologist covering all the work for the 3, basically, for some period of time. And they asked if there is a method like AI or something that can help them at least do this segmentation part of the process, of the workflow. And the problem was they didn't have enough data, so and they couldn't exchange the data because they would violate privacy laws. So what they arrived, they did the small trainings in each medical center separately, with not so good results. So precision was below 50%. So precision of the correctness, let's say, of the AI model. But when they exchange the models and when they find a way how to combine them, they created a bigger model that was trained on a higher amount of data without actually changing the data. So they kind of bypassed these privacy rules without infringing them. And with them, they were able to achieve precision or this correctness of the model on more than 80% of the cases, like 78 to 82% of the cases. So which demonstrated the usability of this method. So this method will have, in the next years to come, we will see much higher application of this method for sure.
Okay, thank you very much. Any questions for Ivan? More questions? No? Well, okay, in that case, we can thank again our presenter for very interesting topic, and thank you for sharing this with us. And we wish you a lot of luck in your future endeavors in AI. Thank you.
And thank you for the possibility to present, and thank you all for listening.
Yes. Okay. Goodbye, everyone, and see you in the next webinar.